Today's webinar will begin in 3 minutes. Today's webinar will begin in 1 minute. Welcome to today's webinar, Global Control of Hepatitis C Virus Infection and New Strategies for Prevention. I would like to introduce Andrea L. Cox, MD, PhD, Professor of Medicine and Oncology at the Johns Hopkins University in Baltimore, Maryland. Welcome, Dr. Cox.
Thank you. Thank you so much for the invitation, and thank you to all the listeners for joining in today as we talk about global control of hepatitis C virus infection. So first, I'd just like to remind everyone, if you've not previously logged in to the new website, you'll need to use your email address and reset your password to update your account. I'd also like to provide a reminder that if you're claiming CME credit for this, the IAS-USA designates this activity for a maximum of 1.25 CME credits. This webinar is also approved for 1.25 hours of nursing and pharmacy credits. And lastly, I'd like to point out that evaluation will be available in your IAS-USA My Activity page by 5 p.m. Pacific time today. That's 5 p.m. Pacific time today. I'd like to thank the supporters for activity. Generous support has received from the following contributors shown on this slide. Okay, just a quick note on navigating the webinar. There will be a separate window that will show the poll questions. You'll want to choose your response from the poll, not the chat box. And please type your questions into the chat box, and I will either answer them at the time they're asked, or if it would be better to do so at the end of the presentation. And for each poll slide, which we'll go to the next to show this, for each poll slide, you should answer the questions as is indicated here. We're starting with which geographic region you're from. So it looks like we actually have a lot of people from all across the United States, and I'm really pleased to have everybody here from different parts of the country, and a few people from outside the U.S. as well. Okay, with that, the second poll is a quick question. When will the evaluation for this webinar be available for you to claim credit? It will spare everyone by not singing when the moon hits your eye like a big pizza pie. Okay, next poll question. Okay, thank you for completing the poll questions. So now on to the presentation. Again, thank you everyone for joining. And I would like to note that neither I nor those who've reviewed this activity have any relevant financial disclosures. So with that, we'll proceed to the learning objectives. I'm hoping that upon completion of this webinar, you'll be able to list the goals for global control of hepatitis C virus infection, to identify some of the challenges in Hep C global control, and to describe current strategies for development of a preventative hepatitis C vaccine. So this is the first pretest question. Okay, and the second pretest question. Okay, now on to the presentation. So the World Health Organization set 2030 targets for viral hepatitis global control. And this is really primarily driven by hepatitis B and hepatitis C, which are the major causes of death from viral hepatitis globally. And their goals included achieving a 65% reduction in liver-related deaths, 90% reduction in new infections, and that 90% of patients be diagnosed. And of those, additionally, they asked that 80% of the patients diagnosed be referred for treatment if eligible. So in addressing those goals, I want to talk about some of the reasons for this big drive towards viral hepatitis control. And the first is that the problem is very large and increasing, as is shown here. So these are the four major global killers from infectious disease sources worldwide, and their disease is familiar to all of us. Malaria in green, the green line, HIV in red. The yellow line is the number of deaths in millions for tuberculosis, and the blue line is the number of deaths from hepatitis C and hepatitis B in their chronic forms. And you can see that the global mortality from HIV, tuberculosis, and malaria have all been declining over the last decade, which is an extraordinary achievement of people all around the world. In contrast, the number of people dying from hepatitis C and B over time has risen and is projected to rise even more in the coming several decades. And so this urgent and problematic situation is in part what prompted the WHO to strive for elimination. What gives promise to this is the fact that we now have excellent vaccines against hepatitis A, hepatitis B, and hepatitis E, including a new vaccine licensed for use in the United States against hepatitis B recently. And we also have antiviral medication that suppress hepatitis B, and with the advent of direct-acting antivirals, or DAAs, we can achieve what's termed a sustained virologic response, which is really curing hepatitis C. So this really drove a lot of optimism that these important medical problems and their rising rates of mortality globally could be addressed if we focused on them. So I'm going to report on how we're doing on this with the study that was released in 2019 that assessed the progress made in 45 high-income countries and territories towards meeting the 2030 HCV elimination targets set by the WHO for incidence, mortality, and diagnosis. So this study is by Homi Razavi and his group, including Marcus Kornberg, and they looked at demographic data obtained from the United Nations World Population Prospects, as well as epidemiologic data from the Polaris Observatory. And in looking at these 45 high-income countries, what they found is that 80% of high-income countries are not on track for the WHO elimination targets by 2030, and in fact, 67% were off by more than 20 years. So if we look at the year of elimination by HCV country or territory, on the left side you can see the names of the countries, and in green are those countries that are on target to eliminate HCV by the 2030 guidelines. Going down the line, you see countries that are having increasing difficulty eliminating or attempting to meet the elimination goals, with the red countries all being countries that are not expected to eliminate HCV by 2050. So showing this on a map on the next slide, again, there are lots of gray countries on this map because this is restricted to 45 high-income countries, but you can see that the countries in red are those not expected to eliminate by 2050. And importantly, I want to point out that they failed across multiple metrics, but that the biggest problem was actually meeting the incidence target. So the goal, again, was to reduce incidence by 2030. 34 of the 45 countries could not meet the incidence targets, 30 couldn't meet the mortality targets, and 22 could not meet the diagnosis targets by 2030 if we continue as we are. So I'm going to talk a little bit about achieving control. Very simply put, the number in HCV-infected people must substantially exceed new HCV cases. So in order for us to basically control HCV, the number of people cured, which is the good way to eliminate hepatitis C-infected people from the population, and the number of people who die, which is the bad way to eliminate them, must exceed the number of new infections. So we have to reduce the number of infections by more than new infections occur in order to achieve control. So looking at another study by Andrew Hill's group, this study looked at epidemiologic data extracted for 210 countries for 2016 and found that actually there were only 91 countries of those 210 with enough data on sustained virologic response or cure, HCV-related deaths, and new infections available to complete the analysis. But in looking at those 91 countries, the group found that 54 of the 91 had more new HCV infections than cures in 2016. In fact, there were multiple countries that actually had more than 5 new infections for every person cured, shown here. So you can see the number of people achieving cure, or SVR, in 2016 plotted against the number of new infections. And these are countries in which the ratio of new infections was at least 5 times the number of people cured or who died of hepatitis C. So when you look at all 91 countries, the total burden of hepatitis C dropped from 57.3 to 56.9 million, which is about a 0.7% reduction. Although, again, there were not data for the 210, if you extrapolate to the rest of those countries and globally, we essentially see a net change of 0.4%. And unfortunately, what this says is that before we began direct-acting antiviral therapy, we had about 70 million people infected, and we have about 70 million people infected after therapy. So we really need to think about other mechanisms. We've focused a lot on cure, which is very important, and I'm just going to talk about the need, the problems associated with focusing on cure and the need to maybe think a little bit differently. Cure is extremely important. However, treatment does remain expensive and inaccessible in many parts of the world. If we look at the prevalence of hepatitis C, or the number of infected people in millions, and these colored lines indicate in the barcode you can see which countries, what the burden of disease is in high-income countries versus middle-income, both upper and lower middle-income, and low-income countries, you can see that there's a tremendous burden of disease in lower and upper middle-income countries that neither qualify for reduced DAA pricing strategies from manufacturers, nor do they actually have sufficient funds to pay for therapy. So this remains a problem. We've also already treated many of those easiest to treat. We've spent in between 2014 and 2017 about $60 billion US on direct-acting antivirals. But as many people see in our clinics, the numbers of new patients initiating DAAs is declining. And the reason the number is declining is that many of the patients who were accessible, diagnosable, and treatable have in fact been treated in many middle and high-income countries. It's also very challenging to find the people who need treatment. Why is that the case? Because the disease is actually often silent until end-stage liver disease, and while it may cause some symptoms, they're often not symptoms that prompt people to seek attention, and they're not specific to hepatitis C until end-stage liver disease. The highest risk groups, which include those living in endemic countries and people who are injecting drugs and other groups, remain marginalized, and many of those who are infected remain unaware. In fact, if we look at this, these are data obtained from the Polaris database, and Andrew Hill provided me with this slide kindly. If we look at the percent of people diagnosed with HCV, and again, the WHO target of 90% is at the top, and we look from left to right, from high-income to low-income countries, we can see that the range is, at best, 44% of people who have Hep C being diagnosed across the globe. So we clearly need to make some improvements there and make sure that those who are infected are diagnosed. This is in part what prompted a recent change in U.S. guidelines to simply test everyone rather than just the baby boomers for hepatitis C virus infection. An additional problem is that the direct-acting antivirals do not provide protection against reinfection. So those who remain at ongoing risk of infection, such as healthcare workers, people who inject drugs, and men having sex with men, particularly HIV-infected men having sex with men, can and have been reinfected following treatment. To provide a bit more detail on that, I'll go through this study from Midgard et al. Looking at patients between 2004 and 5, these were treated people who injected drugs who had been abstinent from drug use for at least 6 months prior to initiation of DAA treatment. Of HCV treatment. And they were basically treated between 2012 and 2014, 94 of them, and they achieved sustained virologic response, and they were followed for on average 7 years. And the results were as follows. There are 37 of the 94 people who are injecting drugs who achieved SVR, or 39% who relapsed into active injection drug use, putting them at risk for an infection. And in fact, HCV reinfection occurred in nearly 13% of these patients in that 7-year period of follow-up. a study in 114 HIV-infected men having sex with men who had achieved sustained virologic response by Martin et al., in which the men were followed for a median follow-up time of 2.1 years, revealed similar findings in that there were 27 reinfections in the 2 years of follow-up, and HCV reinfection occurred in 24% of those who had initially been cured. So HCV reinfection does occur following treatment. And the last problem I'm going to highlight with treatment is that treatment in the later stages of disease doesn't reverse all disease. And so if we look at this graph, which shows the cumulative incidence of hepatocellular carcinoma with years after sustained virologic response, we can see there is ongoing development of hepatocellular carcinoma. The green line is people who were cured who are not cirrhotic or not thought to be cirrhotic at the time of cure. The red graph shows people who had already been diagnosed with cirrhosis at the time of treatment. So you can see that particularly in people who have advanced liver disease at the time of treatment, they remain at ongoing risk of hepatocellular carcinoma. So we simply can't undo all the damage that's done by hepatitis C. And some of this really argues that we really should think about preventing rather than curing disease. So for all of these reasons, I think it is time at this point to really also focus a lot on the new infection prevention, particularly given that the data show that this is an area in which most countries are failing to meet the WHO targets. So again, we're talking about a 90% reduction in new infections by 2030. That's the goal. And one of the things complicating that is something with which all Americans are now quite familiar, an epidemic of opioid use in North America. And the result of that has been that we've seen a rising number of new acute HCV cases in the U.S. So this shows the estimated number of cases between 2005 and 2016. And while the declining rates of hepatitis B, shown in blue, that we had seen have stabilized and we have not seen ongoing decline in HBV acquisition, we've at least not seen this rise in this vaccine-preventable disease. In contrast, in hepatitis C, the rates of new HCV infection, the numbers of new HCV infections are rising steadily. Where is this happening? This is effectively happening everywhere in the United States. If you look at this map of states, the red states are those in which there has been an increased rate of HCV acquisition in the early years of the opioid epidemic. The states that don't have any color, the white states, those states are states in which we don't have good data. I think that probably many of them are red states, if not all of them. And there are a few states in which the rates have decreased in yellow or remain unchanged in purple. But this is effectively a nationwide epidemic that mirrors the nationwide opioid epidemic. What about globally? Globally, HCV incidence is about 1.75 million in 2015, and that really remains unchanged today. And it varies highly depending on where you are in the world. You can see that there's a fair amount of uncertainty surrounding this, but it's estimated there are at least 1.5 million and maybe as many as slightly more than 2 million new infections annually. These infection risks include contaminated medical equipment, blood supply, going to the dentist and the doctor in some regions of the world, and in much of the world, sharing any equipment associated with the injection of drugs. So prevention strategies include harm reduction strategies such as opiate substitution therapy and needle and syringe services, safe injections and blood supply, and of course treatment, as has been explored and investigated in HIV. Treatment as prevention is of course a strategy, and there are some data to support that treatment of HCV-infected individuals in high-risk groups can prevent transmission to others. So if you treat individuals at risk for transmission, this study showed that even among modest increases in successful treatment of HCV infection among people who are injecting drugs and HIV-infected MSM could decrease prevalence and incidence. And currently in the United States, the guidelines are saying that treatment in the acute phase is best done on an individual provider and patient basis, but that it is at least reasonable to consider watching patients for 6 months to look for spontaneous control of HCV. The International guidelines vary on this, but there's increasing recognition that the harm of taking people who are recently infected and watching them may be not just to the individual, but perhaps the greater risk is ongoing transmission to others. So the guidelines vary, but we may see a change in the U.S. guidelines shortly. So the last thing I wanted to point out, as I mentioned earlier, that HCV RNA, that HCV is possible to transmit again following treatment, and so it's very important to check for HCV RNA rather than antibodies, because antibodies remain positive in those infected even following successful cure. So it's really critical in people who remain at ongoing risk for infection to check HCV RNA rather than antibodies, because as mentioned, infection rates can be very high and has been shown in several studies, both in HIV-infected MSM and in people who inject drugs. So don't forget about HCV RNA, please. And lastly, I really think it's very important to emphasize safer sex strategies. This epidemic of HCV transmission in HIV-infected MSM is associated with the use of devices and other sexual practices that allow sharing of this really bloodborne infection. So the final part of the presentation I'd like to address is really the idea of a vaccine. Those of us who are infectious disease specialists certainly are very familiar with the fact that vaccines can prevent infections regardless of risk factors for acquisition of the infection. And they are, in fact, the only successful technique to date for infection elimination and eradication on a global scale that we've seen. So who would benefit from a hepatitis C virus vaccine? The population that would benefit are diverse, but include, of course, people who are injecting drugs, people who basically are living with HIV with a higher than above average risk, which includes HIV-infected MSM. And I think particularly it'd be good to highlight that people who are living in endemic areas remain at high risk. One of the problems that's been seen in some of the countries with high rates of ongoing transmission is that even with widespread rollout of cure, we are seeing people who are reinfecting themselves because they are, again, putting themselves at risk simply by having a surgical procedure, for example. So the question is, can we actually make a vaccine against hepatitis C virus infection? And initially there was a little bit of dismay about the prospects of this because reinfection does not always result in clearance. So not only does reinfection after treatment occur, but reinfection occurs after spontaneous control of HCV, which made people less optimistic that it was possible to achieve protective immunity through vaccination. But there is evidence of a protective adaptive response against HCV reinfection that I'll outline here. In other words, there is some evidence of protective immunity. To do so, I'm going to introduce a cohort called Baltimore Before and After Acute Study of Hepatitis, or BBASH. In this study, people who were enrolled were 18 to 35 years of age, and they were people who were actively injecting drugs and not HCV infected, but at high risk. So they were HCV antibody and RNA negative, and they were followed monthly. And despite extensive counseling and harm reduction, a subset of them acquired HCV, which you can see by acquisition of HCV RNA in the red bar. And those who, and then shortly thereafter with acquisition of antibodies against HCV. So the most common outcome is persistent infection, with 73% of those infected becoming persistently infected, and 27% spontaneously clearing the infection. And again, as has been seen in other settings, in those who spontaneously cleared infection, we actually saw that about half of those individuals that followed over time had a detectable infection with a different HCV virus. And interestingly, the outcome was quite different. So with the subsequent exposure reinfection, clearance was actually the norm rather than persistence. And 83% of those who'd spontaneously cleared one infection cleared a subsequent infection. So this is a clearance rate that is effectively the reverse of the persistent infection rate that is seen with acute infection the first time. So what is mediating this immunity? I wanted to point out this graph, which is actually fairly typical of reinfection. So you can see in gray the HCV RNA level, and you can see a rise in HCV RNA, and this person was infected with the genotype 1A virus, and there was an ALT, as shown in the black open space, an ALT rise as well associated with that genotype 1 infection. This infection was cleared, and then the person remained at risk and injected drugs and ended up acquiring a second infection, which you can see with the second genotype 1A arrow on the right-hand side. But of note, both the peak HCV RNA and the ALT levels were much, much lower in the second infection, and the duration of viremia was also shorter. So this person is actually fairly typical of a reinfection pattern in that what happens is that the person doesn't just clear the infection again, they do it better, more efficiently, more quickly with lower peak HCV RNA and less ALT elevation. So this is suggestive of induction of an adaptive immune response, and in this study we actually also demonstrated that the individuals who exhibited this pattern had broadening of T cell and neutralizing antibody responses. So this is adaptive immunity. So can we actually do this with a vaccine? Well, first I would argue that we have to try. There's actually been relatively little effort to make a vaccine against hepatitis C, and this graph shows that we've tested several strategies in rodents. A very small subset of them have been advanced to testing in macaques, and before we were not allowed to use them in research chimpanzees. And only 2 strategies using proteins, adjuvanted proteins, and viral vectors have been tested in low-risk humans, people not at risk for HCV, with only 1 vaccine strategy being tested in high-risk individuals. And I'll go into more detail about that trial. Well, one of the challenges of HCV is in making a vaccine is how can we make a vaccine, because hepatitis C is very diverse. HIV is a notoriously diverse virus. Unfortunately, HCV is about an order of magnitude more diverse. And when you look at this map of the world, you can see the HCV genotype that dominates, as is shown in the colored sections of each pie chart, varies depending on where you are in the world. The size of the circle indicates the number of people infected in that region of the world. And so you can see that while there is variability, there is a lot of genotype 1 HCV infection throughout the globe. But because of this diversity, that creates a challenge in HCV vaccine design. So there is the single vaccine test strategy that's been employed, and this is a vectored HCV vaccine. It does not encode the envelope proteins that induce neutralizing antibodies. So this is a strategy designed to induce very potent T cell responses and induce immune responses that would clear infected hepatocytes, if not prevent infection. So only the non-structural regions from a genotype 1b virus were put in, and there are several known T cell epitopes within that region of the virus. So the population that was tested, and I should say this was a prime boost strategy where we vaccinated individuals who were in a double-blind randomized placebo-controlled trial that took place at Johns Hopkins, the University of California, San Francisco, and the University of New Mexico. Kim Page was the co-PI of this trial with me. And in this trial, we enrolled people very similar to the BBASH cohort, 18 to 45 years of age, who were actively injecting at the time of enrollment and at high risk for but not infected with HCV. Enrollment of 545 individuals was completed in 2016, and the goal was to assess the safety of the vaccines, induction of HCV-specific immune responses, and efficacy in preventing chronic HCV infection. We looked at incidence as well, but the major problem with HCV is mediated in the chronic phase of infection, so the goal was to make people more like the spontaneous clearers and not persist when they became infected with HCV. So the design was 2 injections that were administered at 0 and 8 weeks apart. It was an adenovirus from chimpanzee engineered to produce non-structural proteins and followed by a modified vaccinia Ankara virus engineered to secrete, again, non-structural proteins of HCV. We looked at immune responses, and we tested people, and again, they were counseled extensively, enrolled in drug treatment programs and needle exchange and syringe service programs, but we tested for HCV RNA monthly for 20 months and at least 9 months after infection. And the full results of this trial are going to be released at ID Week in October. But I can say that the vaccine did not prevent infection as we wished. So the prevention strategies include to treat opioid addiction and reduce the risk of injections in countries where the world's major risk factor, whether major risk factors for acquisition of HCV include surgical and medical procedures, dental procedures, in addition to using injection equipment that can be disposed of. I think we're going to see a movement in the guidelines more uniformly globally towards treating people with HCV because of their increased risk of transmission of the infection to others. And I just want to remind people again to screen for reinfection with HCV RNA in those who remain at risk, or if you're not clear on risk factors, in anyone who presents with new ALT elevation following treatment or spontaneous control of HCV. Again, we need to remember to counsel our patients on safer sex practices, and I'm looking forward to releasing the full results of the trial in the fall of 2019. So with that, we can do the post-test questions, and then I'm happy to talk about treatment and other questions people have. Okay, so I'm very pleased to see that the vast majority of people got this correct, that actually, unfortunately, despite the WHO guidelines being set for substantial control or elimination of HCV by 2030, the vast majority of even high-income countries will not achieve these elimination goals if given till 2050 to do it. So this really drives home the importance of our screening for HCV, making sure we're treating people and working hard on preventing new infections. Okay, post-test question number 2. So fortunately for everyone, the number of people dying globally from malaria, tuberculosis, and HIV has been declining over the last decade. We've unfortunately not seen similar declines, and in fact have seen rising deaths from viral hepatitis. Someone asked the excellent question, how much of this increased disease can be attributed to improvements in testing? But these are, much of this is basically obtained from death certificates and other epidemiologic data. So I think while increased awareness of viral hepatitis may account for some of this, I think what we have seen is a real rise in disease, and we anticipate that that rise of death due to chronic hepatitis B and C is going to increase, which again is part of the stimulus for the WHO, really raising awareness and trying to basically get control over this disease. Okay, so at this point, I'm going to look at a couple of the other questions. One of the questions that was asked was, China has the highest burden of disease. Is there a problem with treatment? Are there more resistant strains of HCV in China? China does bear a very, very large burden of the global disease of hepatitis C. There does not seem to be any difference in the efficacy of the DAAs, or the direct-acting antivirals, against Chinese HCV variants, and a lot of this is just the very large numbers of people infected and the fact that only a subset of individuals in China are being treated at present. I was also asked if I would treat the individual who was reinfected who had a low HCV RNA level. So if we look back at the slide where the person had cleared or spontaneously controlled a primary HCV infection and then reacquired infection, that is not uncommon to see a very low level of HCV RNA and ALT elevation. And because 83% of those individuals who cleared an initial infection will clear a second, third, fourth, fifth infection, I sometimes do observe individuals who are reinfected. I'm less inclined to do so in someone who's had a major change in immune system function between the first and second infection. So for example, if the person also acquired HIV between an earlier infection and a later infection, I think the person is less likely to clear, and I'm less inclined to wait and watch. And I would also point out that this does not hold for people who were treated with DAAs. So some individuals who are treated with DAAs also clear infection when they're reinfected, but that's much less common and is not the common outcome. So the 83% clearance of reinfections that I noted, that's in people who, on their own immune systems controlled the infection. For many of those individuals, because the duration of viremia is so short in the reinfection, you can actually watch them for a fairly short period of time to determine if they're going to clear the infection. I've been asked if there's a difference in occurrence of new infections between men and women. There are a few studies, including one by Kim Page's group, showing that there is a slightly lower incidence of infection in women compared to men who are injecting drugs. The spontaneous clearance rates differ between men and women. Women have an odds ratio of 3. They are much more likely to spontaneously control HCV. So one question you could ask is, do they have very transient infections that are not even detectable and clear, or are they really less at risk for acquiring hepatitis C? It's not clear, but there are data to suggest they're less at risk for infection, and the data are very clear that they're less likely to become persistently infected. Okay, I think I addressed the question about reinfection in the setting of cure. Those patients are less likely to be cured of infection than the spontaneously controlled individuals, and I do watch them for a short period of time. But generally, people who have been infected following cure will need to be treated again, which is partially why it's important to screen for HCV RNA in those who have been treated and cured, but it's also important to do harm reduction and to make sure that we really do get everybody treated so they don't transmit to others. I was asked, before we design a potential vaccine, do we need to better understand biological control mechanisms that occur in those that recover from infection naturally? I think that's a great point. I think those individuals probably hold the key to what is protective immunity. What's interesting to us about the individuals who are reinfected, and we've seen people clear 6 or even 7 different HCV viruses. I showed an example of someone who was infected with a 1B and a 1B, but we've had people infected with diverse genotypes of HCV and control multiple different, not just different HCV infections, but infections of different HCV genotypes. So these people really do have robust, seemingly broadly protective HCV immunity, and that's something that is being actively investigated because I do think that they have a very important lesson to teach us about what protective immunity against HCV looks like. If we could make individuals, if we could induce an immune response like that with a vaccine, that would be a very, very good vaccine. I think I was asked about the tendency of not treating individuals with low fibrosis scores. I think in the United States we're very gradually, slowly moving towards elimination of the liver staging criteria for treatment, and I think that's going to be important for both prevention of disease in the long run and reducing the number of deaths from hepatitis C, but also in those who are at ongoing risk of transmission to help eliminate the risk of transmission to others. So this is 10 other countries have already more broadly adopted the strategy of treating everyone with HCV infection. That is the recommendation from all the national and international guidelines, and I think that on a state-by-state basis, we're slowly, too slowly, but slowly moving towards eliminating staging as a requirement for advanced liver disease before treatment. There are individuals who have fairly low levels of liver disease, and then for some reason the disease rate accelerates dramatically, and we have people who've been relatively stable who then have more rapid progression. So I think there's no doubt the data support treating everyone. We just need the funds and the will to do it. I was asked what drives China's HCV infection rates. It is possible to transmit HCV infection through the sharing of needles for acupuncture and other needle use. So China has a diverse source of HCV sharing in a variety of different ways that occur more broadly than simply through people who inject drugs, but again, it's a mixed epidemic there. So I was asked about treatment with DAAs if we have antibody positivity and no virus. The virus testing, the HCV RNA test, is very sensitive. It really is an excellent measure. It's been shown that if there is no virus in the blood, there's no virus in the liver. So antibodies stay positive for life in someone who's been treated. So we don't look at antibodies as an indication as to whether someone needs treatment or not. It's really based on the persistence of virus as measured by HCV RNA. So the decision to treat a patient really needs to be made based on the detection of HCV RNA ongoing infection and not just the antibodies. Okay. Let's see. So I've got a question coming up here. Okay, yes. The question is about another set of criteria put in place and restrictions for treatment. There are still some restrictions on the treatment of people who are injecting drugs. There are some insurers and some Medicaid requirements that patients not inject drugs for at least 6 months prior to treatment, and that was in the Midgard study I showed. That actually was a condition that was set in the people who were put in that trial. So they had not injected for at least 6 months prior to coming into clinic. Well, there are two reasons that are out there at minimum to treat people who are actively injecting drugs. One of the big drivers is if you're actively injecting drugs, you're at risk of transmitting the infection to others. So just as with the HIV, treatment as a mechanism of prevention, treatment is a mechanism of prevention that could theoretically have a large impact in HCV transmission. The second is in people who are injecting drugs, occasionally when you diagnose someone with HCV and get them into the treatment centers, you can really focus on a lot of the other drivers and life issues that are facing them. So I think right now, because the guidelines in the U.S. are permitting observation for individuals based on provider preference for up to 6 months, that the insurers can make commentary like that, I think it will be harder to argue that we should be waiting to treat anyone with time, because I think the data are pretty good, that it prevents transmission as well as disease to the individual who's infected. I have a question about sexual transmission of HCV. HCV is a blood-borne infection. It is transmissible mostly by infected blood from one person getting into the bloodstream of another. So this is what I mentioned in HIV-infected men having sex with men, but I appreciate the point about trying to clarify that. When you treat people treat people in the clinical setting, you can see transmission in people who really have no other risk factors other than sexual transmission. But when you query them, and in studies, it's been shown that sexual transmission of HCV is associated with trauma. So where in sexual practices such as device use, where there actually is blood. So I guess it depends on how you define sexual transmission, but in the setting of people using devices and in the setting of traumatic sexual intercourse, such as rape, there actually can be exchange of blood, and that increases the risk for HCV transmission. So while people talk about sexual transmission of HCV, when you get down into the details, it's really, really readily transmitted by sharing needles and other equipment used to inject drugs, much less readily sexually transmitted, and usually in association, again, with blood. I was asked, can you treat people who have HCV, who have decompensated liver disease? We could not in the interferon ribavirin era, but fortunately the direct-acting antivirals do offer the opportunity for treatment of people with very advanced liver disease. This really should be done by an expert because there are risks of the individual having more severe liver disease in the acute phase. So this is highly beneficial in the closely supervised setting in the individual who does not have worsening of disease, but there are some individuals who have worsening of disease and need to be monitored closely. And in those groups, really the people who have hepatitis B co-infection and the people who have decompensated liver disease, those individuals should really be treated in the hands of an expert who can watch them carefully. The other factor is, in some cases, because of the availability of Hep C-infected organs for donation, which is an unfortunate consequence of the opioid epidemic, because of the availability of organs with Hep C for transplantation, in some cases we actually list patients for liver transplant and take a Hep C-infected organ and then treat them following transplantation. So in some cases when people have very decompensated disease, it makes more sense to list them for transplant, get them a liver quickly, and treat the new liver to eradicate Hep C. So again, that's a decision made by people who focus on Hep C management very closely. The other question is about HIV-infected patients. The guidelines list HIV as a risk, as a factor that should drive treatment. It's very clearly been established that people with HIV are more likely to progress to end-stage liver disease, and they should be treated for their HCV. So that is a criterion that most people are following very carefully now, and people with HIV should all be treated for their hepatitis C. Mother-to-infant HCV transmission is the question I got asked, and this is a really pertinent and timely question, and I appreciate it because we are seeing, as part of this rising rate of HCV transmission in this country, we are seeing more mother-to-child transmission of HCV. The reasons for that are not entirely clear. One factor that's very clear is the number of pregnant women becoming infected with HCV is rising. So clearly, because HCV is transmissible from mother to child, and HIV-infected women who acquire HCV are even more likely to transmit. So HIV-infected women, the overall rates are quoted at about 6%. It's lower for women without HIV and higher for women with HIV. So one problem is we have more pregnant women infected, and particularly for HIV-infected women, there's a lot of transmission to the infants. The other possibility that's compounding this is that because of this opioid epidemic, we have women becoming infected with HCV for the first time in pregnancy. They don't have any antibodies yet against HCV, unlike women with chronic infection, and that may make more virus available to transmit to the infants. There's also, in acute infection, a very high level of HCV RNA that is lowered in the later stages of infection. So if women are becoming acutely infected during pregnancy, for those two reasons, the high amount of virus present and the fact that there may not be antibodies around, those could both enhance the risk of transmission to infants. But we actually have seen an unfortunate rise in infants with HCV in this country. And the drugs are not licensed for treating infants. The youngest age at which a child can be treated in the United States is 3 years of age. So we are seeing increased transmission from moms to babies. It's a very worrisome trend. And again, I think, in order to interdict this, a vaccine would really be highly desirable because we would probably vaccinate young, healthy people prior to the onset of injection drug use if we could get a universal vaccine, and that would keep those who end up who end up injecting drugs later at the time when it's hard to reach them. It would keep them from being infected in these key times of life when they're young and at risk for pregnancy or even planning pregnancy. Any other questions that the group has for me? Okay, if not, then I will just remind everyone that you can view this again and acquire CME credits. Others can as well. And again, to remind everyone that by 5 p.m. Pacific time today, you should be able to complete an evaluation for this. And so, final poll. All right, I hope everyone who said "When the Moon Hits Your Eye Like a Big Pizza Pie" is singing it. And on that note, thank you very much for your attention. I appreciate the excellent questions. Have a good day.